Diagnosis of early hypoxia-ischaemia. Unfortunately for the pathologist, most of the hypoxic ischemic conditions seen in forensic practice cause death too quickly for any recognizable histological changes to develop. Acute death from strangulation, suffocation, choking occur within minute or less when expecting the sudden vasovagal type of cardiac arrest. There are, however, occasions where a longer period of survival occurs after an acute ischemic episode, and in some of this, there may be the opportunity to detect histological changes in the central nervous system. Probably, a minimum of 2 to 4 hours of survival is necessary for unequal changes to be observed. Though some neuropathologists claim to detect signs after as little as 1 hour, more caution investigators prefer 4 hours as the minimum. A short postmortem interval is considerable advantages in searching for these changes, as they are subtle and they can be overlaid by postmortem autolysis even if the later is late. It takes 12 to 24 hours from the onset of infection before it can be detected with a naked eye on a postmortem examination of a unfixed brain. When brain is fixed properly, the early infect can be identified by palpation because necrotic tissue does not become fixed. Soft and velvety to touch in contrast to the firm consistency of the fixed non-necrotic area. The blurring of the boundary between the grey matter and white matter is another rarely macroscopic change. It may be helpful to seek the assistance of a neuropathologist to detecting or confirming the relative minor changes seen in a brain affected by hypoxia. But with the experience, a good knowledge of the normal appearances, and a laboratory that is able to turn about constantly good quality sections and uniform staining, any forensic pathologist can build up a considerable expertise in this localized aspect of neuropathology, the part of the brain most suitable for seeking evidence of hypoxic damage are the hippocampus, especially the CA1 sector, Somner's area or subiculum, cerebral folia, the global spinous basal ganglia are the boundary zones of the cerebral cortex where the brain matter is most vulnerable because it lies at the terminal reaches of the arterial supply. For example, parasagittally at the middle frontal gyrus, where the watershed area between the middle and anterior cerebral artery lies. Third and fourth cortical layer are best for displaying the histological changes of hypoxia. The following is a summary of the stages and changes that may be seen in different staining methods. The brain should be fixed by suspension in a bird 4% formaldehyde, though if this is impossible, so some blocks should be wet out, cut from target area of the brain mentioned above, and immediately fixed in a large volume of buffered formaldehyde. The earliest change is microvacuolation in the neuron cytoplasm, swollen mitochondria, which may be seen in 2 to 4 hours. The cell outline remains smooth and its size is normal, but internally some vacuoles appear in the cell body and the proximal part of the axon and dendrite. There may be little eosinophilia in a hematoxylin and eosin stain and a violet color in the looks all fast blue. Microvascular changes is said to begin earlier in small neuron and short for a long and last for a shorter time, being present for up to 4 to 6 hours after insult in large cells and 2 to 4 hours in a cerebellar Purkinje cell, though these times are arbitrary. In stage 2, the next stage, more prolonged hypoxia-ischaemia causes distortion in the shape of the neuron, the cell body becoming shrunken and staining darker with aniline dye. The nasal granules become fine and more dispersed more widely throughout the cell. More some vacuoles remains. The cytoplasm shows marked eosinophilia and in a H&E stain and is bright blue to more in a LFB stain. The nucleus becomes triangular and be placed eccentrically in the cell body. The nucleolus becomes obscured and nucleus condensed. Pyknotic and it stains a dark blue than normally with LFB. This changes is seen after up to 4-6 hours survival or later in larger neurons. Stage 3. The ischemic cell stage described last becomes worse during the day or 2 if survival continue. The cell shrinks further, becoming narrow and tapered in many cases. Eosinophilia and blueness when stained with the LFB persist, but a small spherical or irregular bodies begin to adhere to the exterior surface of the cell membrane. This incrustation persists longer than the remnants of the cytoplasm, which vanish, leaving the bare nucleus. The dark shrunken nucleus becomes more apparent and survives for days before karyolysis occurs. As an inflammatory reaction to the evolving necrosis, polymorphonuclear neutrophils accumulate by 15 to 20 hours in the lumen and perivascular space. A small artery supplying the territory of the small infant. And if the ischemic injury to the blood vessel is of sufficient variety, PM are infiltrate to the brain parenchyma. Stage 4. Homogenizing cell damage is best seen in Purkinje cell, in which the cytoplasm is uniformly eosinophilic with no nasal granule. The nucleus stains dark and triangular until it vanishes and leaves a pale ghost of the cell body with a vague perimeter. Blood-derived monocyte phagocyte appear on 2 to 3 days. Begin phagocytosis of the cell debris, in which the activated phagocytic microglia cells, which actually are non-glial cells but monocytic reticular endothelial cells residing in the CNS are also participate. Proliferation of astrocytes, which show mitosis, begins some 4 to 6 days later if the patient survives. This is most noticeable in the cerebral and persists for 10 to 14 days. Astrocytes proliferate but not the oligodendroglia. A later stage of cerebral hypoxic ischemic, in fact, during a cystic cavity lined by astrocyte with lipid-laden macrophages form cell which may persist for several months in large. In fact, thank you.